We're hosting this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, the Tsleil-Waututh Nations, and the Métis Charter Community of the Lower Mainland region. And as the weather changes and hopefully the air changes, we are again reminded of our role perhaps in the stewardship and the respect of the land, as well as the people who have tended it before us and now us with them. And hopefully all of us reflect on elders past, present, and emerging. Next slide. So Province-Wide Rounds is a collaborative venture between UBC Division of Nephrology and BC Renal, supported by all of you in all of the health authorities, as well as generous unrestricted donations from various pharma partners that help to improve scope and scale of the educational activities and opportunities that we are able to offer. Next slide. So it's a great pleasure to introduce Dr. Megan Borkum. Megan completed her MD-CHB internal medicine and master's in medicine and nephrology at the University of Cape Town in South Africa. After that, she completed a research fellowship in hypertension at University College London, and then came to BC, where she's done an advanced nephrology training fellowship in 2021, during which she also completed the Harvard Medical School Global Clinical Research Training Program, and is now a home dialysis fellow in the current academic year. Her clinical and research interests include cardiometabolic disease, cardiovascular risk reduction in CKD and dialysis patients, and improving life participation for home therapy patients. And so she's really managed to do a lot and perpetually improving both her skills, knowledge, and its application. So with that, I'm going to hand it over to you to tell us about exercise dialysis spectrum in dialysis patients. Thanks, mate. Dr. Borkum.
Good morning, everyone, on this rainy day. I hope everyone can see my slides. So I'm going to discuss exercise across the dialysis spectrum. I know I'm a home dialysis fellow, but I want to extend the enthusiasm and help build the culture of exercise in all our dialysis patients. I'll specifically focus on the role and integration of exercise in end-stage kidney disease management and try and shift the focus from the traditional paradigm of dialysis adequacy, managing fluids, and lab parameters to more prevalent issues for patients themselves, which include, as we know, the end-stage kidney disease symptoms, a lot of mental health issues, as well as feelings of poor productivity while on dialysis. So we're shifting towards more patient-focused outcomes, targeting what matters to me in each patient. However, there's still a big challenge in introducing exercises, motivating patients, as well as sustaining consistent exercise programs across dialysis, and of course also in CKD and transplant patients where there's also a role. I hope to give you some information and tools to do this through this talk. So unfortunately, I have no financial disclosures. And although I do have a keen interest in the topic and have read a lot around it, I'm by no means an exercise professional or scientist or expert, but I do like to think that I like to practice what I preach. In this talk, I'll highlight the importance of exercise in kidney disease, discuss the evidence base for the topic, look at ongoing and future trials, of course, focus a bit on PD and home hemodialysis, mention obstacles to implementation of successful programs, and share some resources that I've developed with some colleagues and what is available online in this area. I'll also briefly mention 2 pilot projects which I've been involved in BC and share some notable findings from the projects. I know definitions are boring, but I have to start with them. So we do tend to often use the term physical activity, exercise, and lifestyle synonymously, but it's important to remember that they have unique differences. Physical activity is defined as any bodily movement produced by skeletal muscle that requires energy expenditure. Exercise is itself a subset of physical activity that's regular and structured, and lifestyle refers to a way of living that lowers the risk of being seriously ill or dying early. We all, I hope, know that being active is important. There's strong evidence over the many years to show from hundreds of studies that in general, exercise improves components that influence the quality of life, including physical, psychological, and social factors. Through different mechanisms, exercise improves health, including reducing body fat, increasing muscle size and quantity, enabling more effective use and storage of blood glucose, reducing levels, as well as controlling other cardiovascular risks such as inflammation and blood pressure, and improving blood pressure health. But why is this important specifically in kidney disease? So sorry, I know this is a bit of a busy slide, but it's just for you to appreciate the big picture. Looking in some studies, pedometer studies specifically on patients in their CKD journey, it's appreciable that as the kidney function worsens into dialysis, patients took significantly fewer number of daily steps. So this is an example of the well-recognized concept that exercise tolerance and physical activity levels worsen with advancing CKD due to associated frailty and sarcopenia. And this ultimately leads to functional decline and disability with increased healthcare costs and mortality. Rehabilitation, meaning recovering or restoring what is necessary to get on with living, has sadly been a low priority in most dialysis facilities. The inclusion of integrated rehabilitation programs for dialysis patients is not routinely offered as patient care. However, increased physical activity and exercise do offer patients the chance to enhance their confidence in performing physical activities, attenuate the well-recognized deterioration of physical function that occurs in these patients, and the associated limitations of activities of daily living, and enhance ultimately the quality of life in these patients. Last of the definitions, I promise. Cardiorespiratory fitness is defined as the ability of the circulatory and respiratory systems to supply oxygen during sustained physical activity, and is usually expressed as the maximal oxygen uptake, or VO2 max, during maximal exercise testing. There are various ways to measure VO2 max, most accurately being in a lab with specialized equipment, but it can be calculated without equipment, and a lot of smartwatches calculate it now. Cardiorespiratory fitness is a very important consideration because it's a recognized strong predictor of mortality. Low cardiorespiratory fitness presents a particularly high risk of death, and this compared to other common risk factors such as diabetes, high cholesterol, or hypertension. And this is true in patients with CKD, where cardiorespiratory fitness is an independent predictor of mortality, regardless of eGFR. So in this graph, you can see healthy populations, which are represented by the solid blue line. And these are mean peak VO2 max levels. And we can compare this to CKD stage 1 to 3, where levels reduce dramatically, and levels reduce even further once patients start dialysis. After transplant, there is some recovery, but not to pre-morbid levels. And these data are aggregated from various studies on the topic. This is a very nice review in Nature, if anyone wants to jot down the reference. So we've all experienced the vicious cycle of decreased physical functioning and reduced physical activity in our patients. Manifestations of renal disease, including uremia, inflammation, and malnutrition, elicit catabolic effects that reduce exercise capacity and thereby physical functioning. Reduced physical functioning interferes with daily physical activity, leading to reduced anabolic stimuli and eliciting a cycle whereby decreased anabolic stimuli compromise muscle mass, muscle strength, and cardiorespiratory fitness. Moreover, metabolic acidosis also affects physical activity through fatigue. This is a very nice visual example, which is a cross-sectional thigh CT of a patient at baseline and 6 months after starting hemodialysis, where the gray muscle mass becomes visibly smaller and replaced by white fat. So bringing things back to Canada, kinesiologists from Alberta were pioneers in this area, working with exercise in kidney patients now for over 15 years. They have a great model where they cover patients at all stages of their kidney journey, even working in prehabilitation to optimize patients for transplant. So essentially using exercise as a component to enhance patient functional capacity prior to surgery to improve their tolerance for the upcoming physiologic stressor. They also importantly target fall prevention through strength and balance training. And they really do focus on empowering patients by, if possible, giving them self-management tools prior to medication for symptoms experienced. As well as offering intradialytic exercise, they also have a home equipment loan program. Similarly, in Manitoba's program, they offer clinics and counseling, focusing on wellness, both in person and online. They have a prolific research unit, including Dr. Clara Bohm, who's written and well cited in this topic. And they're currently completing a renal rehab trial in dialysis patients, which I will discuss a bit more later. Before we delve into the studies, I'm going to highlight some commonly used outcome measures in studies of exercise in end-stage kidney disease patients. These include hand grip strength, which is measured using a dynamometer as a surrogate for upper body strength. The 6-minute walk test, which I'm sure many of you are familiar with, where patients walk as far as possible in 6 minutes, measuring the cumulative distance walked between two cones, and this is usually about 20 to 30 meters apart. Also, the 30-second sit-to-stand test, where the patient sits in the middle of the chair with their hands across their chest, crossed at the wrists, and they have to rise to a full standing position and then sit back down as many times as possible in 30 seconds. There are numerous generic and disease-specific symptoms and quality of life assessment tools. They've all been validated, but no one is better than the other, but many different ones have been used in the literature. So what is the evidence that exercise is beneficial in dialysis patients specifically? So this is a great Cochrane review from 2022, and it included 77 studies in adults on maintenance dialysis and any exercise program of 8 weeks or longer, targeting more than one muscle group. The only comparison in these randomized controlled trials was no exercise or a co-intervention given to the control group. Only, unfortunately, a small number of studies were done in PD patients of apparent poor quality evidence and with bias identified. So the review concluded that moderate certainty evidence was found for improvement in the outcomes of depression and functional capacity measured by the 6-minute walk test. Improvement in the health-related quality of life and physical component score, pain and fatigue, was found with only low quality evidence, and poor quality data for an improvement in mortality as the outcome was identified in only one study. But is exercise safe in dialysis patients? So this Cochrane review found that adverse events, which were mainly shortness of breath, soreness, and musculoskeletal injuries, were poorly reported and listed as an outcome in only 15% of included studies. Reassuringly, no one died due to the exercise intervention. However, overall study quality was downgraded due to the short duration of the intervention and follow-up, and multiple types and sources of bias were identified. In April 2021, the UK Kidney Association published the first ever clinical practice guidelines for exercise and lifestyle for those living with a kidney condition. These guidelines summarize the latest evidence and include recommendations for physical activity and exercise. The grade framework, where 1A evidence is the strongest and 2D the weakest, was used to evaluate the quality of the evidence and to guide clinical practice points. You can see the quality of the evidence for the benefits of exercise is similar to the Cochrane review I just discussed. Another question which is often asked to me by people working in PD is exercise safe for PD patients? So exercise therapy for people receiving PD historically has not been included in routine care, in part due to this ongoing uncertainty about the safety and the risks involved. So this was a review which was published in Peritoneal Dialysis International this year, which aimed to systematically explore data on adverse events experienced by people receiving PD while undertaking an exercise intervention. They only found 25 studies, and of these, 17 of the 25 provided adverse events data and were included. There were no serious adverse events, so no death or hospitalization were found attributable to the exercise intervention. And of 50 reported adverse events during the intervention period, only 32 were attributable to the exercise intervention, with most being musculoskeletal, like muscle, joint, and pain, followed by fatigue. Events were mild to moderate in severity and were resolved by simple fixes, so exercise program modification, education, rest, or simple analgesia. There was no signal for increased risk of PD-related complications, such as leaks, hernias, or PD-related infection. So therefore, this review did not uncover signals of harm. However, it does conclude by recommending improved adverse events reporting in future trials and further large interventional studies on this topic. This is Brett Tarker, who's a well-cited Australian exercise physiologist, actually doing his PhD on exercise and PD. He's an active member of the Global Renal Exercise Network, wrote this review, and as well as contributed to the ISPD PD exercise guidelines. And he says, based on the available studies, this is the strongest indication to date that the risk for adverse events for people receiving peritoneal dialysis who engage in exercise or physical activity is low. So a growing area of research interest is looking at exercise to improve symptoms of end-stage kidney disease. These unpleasant symptoms interfere with the population's quality of life and feeling of well-being, which we're all very familiar with. Symptoms are common. 30 to 80% of patients on dialysis have at least one symptom, and the symptom burden is high, with 6 to 20 symptoms endorsed per individual. Uremic toxins are often believed to be an important cause, but we can all attest that symptoms often persist even in the face of presumably adequate dialysis. Considering symptom treatment, adding pharmacological therapies with associated possible side effects is not well accepted in a population already facing polypharmacy. In line with the Living Well with Kidney Disease Consensus Conference held in 2021, it is of paramount importance to reframe clinicians and other multidisciplinary providers' perceptions of person-centered approaches to guide the effective management of symptoms in CKD. Approaches such as exercise programs were considered to offer personalized, patient-centered care and treatment. So what evidence do we have for using exercise as a non-pharmacologic tool for mitigating end-stage kidney disease symptoms? So this is a 2021 C-JASON systematic review and meta-analysis, which explored the effect of aerobic exercise on HD-related symptoms in patients on maintenance hemodialysis. They included studies with intervention duration of more than 8 weeks, with at least 2 sessions per week of at least 20 minutes duration, and the comparator was no exercise or sham exercise and usual care. So only 15 randomized controlled trials were included. However, they screened 3,048 trials, and aerobic exercise did seem to improve several symptoms. There was a 35 to 40% reduction in symptoms of depression, and a 20-minute walking intervention after dialysis reduced muscle cramp frequency. 20 minutes of cycling in the first 2 hours of dialysis session reduced fatigue. However, the risk of bias was unclear or high for most studies due to uncertainty over the randomization method and allocation concealment. There was lack of blinding and no reporting of exercise program adherence or adverse effects. They used various generic and specific symptom assessment tools such as the ESAS Renal and the Beck Depression Inventory Score. Therefore, although they suggest improvement in end-stage kidney disease symptoms, particularly restless legs, cramping, fatigue, and depression, trials are limited in numbers and by the methodology used. Fortunately, there's a growing interest and list of recently published and recruiting exercise trials in end-stage kidney disease that are utilizing newer diagnostic technologies, for example, high-resolution echocardiography, and they include wide-ranging measurable cardiac and clinical outcomes, such as myocardial stunning and, of course, hospitalization and mortality. This is the Cycle HD trial, which I'm sure a lot of you are familiar with, which is a cluster randomized trial in 6 centers in the UK. They found an 11.1 gram decrease in left ventricular mass by cardiac MRI after only 6 months of intradialytic cycling. Additionally, other markers of cardiovascular disease, including aortic stiffness and potentially myocardial fibrosis, improved. The dropout rates and serious adverse events were acceptable, and the trial, however, was unfortunately unable to show a statistical difference in physical function or quality of life, but does offer hope to encourage further work into the pertinent area of cardiovascular risk reduction in dialysis. So, does exercise reduce the risk of hospitalization and death in dialysis patients? In the exercise introduction to enhance performance in dialysis, quite a mouthful, the EXCITE trial, which was published back in 2017, a 6-month home walking program during the non-dialysis days, improved functional status, as well as lowered the risk for hospitalization in HD patients. The hospitalization risk was a secondary outcome in the study. In a post-trial observational study recently published this year, the lower risk for hospitalization from the walking program registered in the per-protocol analysis of the 6-month EXCITE trial was maintained for 30 months after the end of the trial, particularly in those patients with high adherence to the 6-month trial. The long-term risk reduction even occurred despite a minority of patients, so only 30% in the active arm of the trial, maintaining the walking program long-term. This is really encouraging. However, despite suggestions for this benefit, it's important to remember that this is an observational trial, and clearly more experimental trials adequately powered for this outcome is required. So looking to the future, I haven't included studies related to transplant in this. However, there are some looking more into the area of prehabilitation affecting post-transplant outcomes. But these are all HD-related future trials or newly recruiting trials listed on clinicaltrials.gov. You can see that cardiac protection, specifically intradialytic myocardial stunning, using dynamic imaging such as high-resolution echo for assessments is a big focus. The previously mentioned renal rehab study in Manitoba was set to recruit 150 patients, and results are expected next year. This was a 6-month supervised renal rehabilitation program in maintenance HD patients, and it's assessed the change in dialysis symptom index, which is a questionnaire including 30 items targeting a specific physical or emotional symptom in hemodialysis patients, and they look at this change as a primary outcome. Just to show you the dialysis symptoms index, I know we're all familiar with the ESAS Renal. This is a validated symptom prevalence and severity score. It was developed in 2004 with patient focus groups being integral in its development, and it's subsequently been included in a lot of studies on the topic. It's also been adapted in various cultural settings. This definitely has not been tested head-to-head with other scores like the ESAS, which has 12 items and is scored from 1 to 10, but it does include more patient-centered symptoms. And of course, I have to mention the home therapies. Specific to exercise in home therapies, evidence is even more scanty. As with the nature of an independent dialysis, the main thing to remember is it's important to facilitate some flexibility of dialysis schedules to allow for time to exercise. A priority should be accommodating dialysis around patient preference and routine for exercise. Looking at PD, with a growing body of evidence, the Global Renal Exercise Network and International Society of Peritoneal Dialysis reviewed the published literature and pooled international clinical experience to formulate a set of clinical practice points on the topic. These were published in PD International at the end of 2021. Practice points centered around a set of exercise and activity-related questions developed from the perspective of a PD patient. And the review of the literature found sparse quality evidence. And so the clinical practice points are generally based on the expert consensus of PD patients, PD exercise expert clinicians, and PD exercise researchers like Brett Tarker. These guidelines address the timing of exercise and activity, so work, sex, swimming, and core exercises, the potential adverse outcomes related to activity and exercise. So, for example, exercise care and perspiration, fatigue and raised intra-abdominal pressure, as well as the effect of exercise on conditions of interest, such as mental health and frailty, and exercise and nutrition. Remember the grade framework, where 1A evidence is the strongest and 2D the weakest. This was used to evaluate the quality of the evidence and to guide clinical practice points. I do recommend a read of the guidelines. They make for interesting reading. Home hemodialysis patients are another unique population that has previously been excluded from exercise studies. I'm not aware of current or planned intradialytic exercise studies specifically in home HD patients, presumably since most intradialytic exercise trials are held with exercise professional supervision. Encouragingly, though, for the design of future trials, although modality-specific guidelines and protocols would vary, in a survey to assess perceived benefits and barriers to exercise, mostly similar motivators and barriers to exercise were found across all modalities, so PD, in-center HD, and home hemodialysis. Major barriers that were common across all groups were too tired, too weak, and shortness of breath. The major differences were actually found by age group rather than the dialysis modality, but all agreed exercise is important. Looking at barriers and limitations to initiating and sustaining a dialysis exercise program. The biggest barrier is the universal lack of exercise professionals in this arena. Exercise professionals, meaning physiotherapists, kinesiologists, rehab assistants, have been instrumental in encouraging patients' adherence and motivation and sustaining programs, and this has been recognized consistently in all literature on the topic. Unfortunately, these professionals are not standard members of the dialysis interdisciplinary team. Further, the role of the exercise professional, whether simply in implementation of the program or for day-to-day provision of intradialytic exercise, has not been clearly delineated. Many nurses have been found to be excellent exercise champions. They are responsible for maintaining the program in centers participating in intradialytic exercise programs. However, as I'm sure we could all attest to, staff workload frequently arises as a primary barrier to sustaining intradialytic exercise. Therefore, formalizing the role of exercise professionals by building in an assessment of the impact of their involvement on outcomes in large randomized clinical trials on the topic does seem pivotal to advocate for their inclusion in dialysis teams and the continued success of intradialytic exercise programs. A high dropout rate is also a challenge in such projects. This trial was a multi-center retrospective observational study published in NDT this year. Overall, 980 patients were enrolled in the study, and the study aimed to investigate the dropout rates from an intradialytic exercise program at 6 and 12 months in patients undergoing hemodialysis and to identify dropout predictors. The dropout rate at 6 months was 26.4%, 24.1% between 6 and 12 months, and cumulatively 44.3% at 1 year. In this study, low physical walking capacity, older age, inflammation, and high target ultrafiltration volumes were determinant of dropouts from the exercise program. Gamification of exercise, I like that word, and the application of wearable technologies have been suggested as an effective tool to enhance patient involvement and adherence. A novel 12-week Spanish trial of intradialytic, non-immersive, so video game format, virtual reality exercise was carried out, and patient physical function measured by gait speed and 6-minute walk tests improved significantly, while adherence rates exceeded 80%. This is some food for thought. Moving swiftly along to our local pilot projects. These projects are small, mainly aimed at assessing feasibility. I will mention the meaningful findings in both of them. So Fraser Health has expanded their intradialytic biking in the community dialysis units. Along these lines, in the first project, over a 12-month period, 24 patients in the New Westminster and Abbotsford home hemodialysis program received a bike to try at home after medical clearance by the nephrologist. 20 patients completed all surveys and questionnaires, and 16 out of 20 patients actually used the bike 2 or more times a week, with a mixture of these using it on and off dialysis. The bikes were demonstrated by the renal dietitian, and various models were available. Assessments were the ESAS renal and hand grip strength, as well as study-specific surveys designed to get more feedback on the project with the aim of eventually growing the project. This is a checklist used for medical screening. Factors such as recent myocardial infarction, significantly uncontrolled blood pressures, as well as active infections are obvious contraindications to participation. So the group of the 16, 44% were female, a large majority were Caucasian, and you can see that the mean age was 57 years, which one would expect with home hemodialysis independent patients. Interestingly, looking at the ESAS scores, there was improvement in particularly these 3 symptoms in a large number of patients. So the symptoms were restless legs, depression, and feelings of well-being. Of course, we can't infer statistical significance because the numbers are small, but this is very interesting and is in line with the literature I previously discussed. I found these comments really nice to read, so I'll just read a few. A patient said, "I'm a wee bit happier as it gives me something to do and look forward to. I was able to be active even when feeling unwell because biking was easy to do and right in my own home. I was always motivated to exercise, but the biking helped me to fit it in. Outside of dialysis, I noticed I was able to walk more. It made me feel more active, so I wanted to be more active. It cut down on the boredom during dialysis and made time go faster," which is really nice, I think. This is a typical biking prescription. So cycling is mostly of the moderate intensity, and this is measured by the Borg rating of perceived exertion scale. So how hard you feel like your body is working. Every session routinely comprises of a warm-up period, main body, and cool down, and generally increases incrementally in duration over time as patients improve their fitness. The other pilot program I want to discuss is from St. Paul's Hospital, involving maintenance in-center hemodialysis patients. Numbers are small, but again, this is a pilot project. 10 patients were included. This was a 6-month intradialytic personalized exercise program, which included over 30 minutes of biking, as well as upper and lower limb resistance exercises per session. The exercises were devised by a physiotherapist and later supervised by a rehab assistant and a wonderful volunteering kinesiology student. Equipment used were various models of bikes, such as the Monarch stationary bike and the XC bed bikes. Ankle weights and dumbbells of various weights were used, as well as different therabands. And outcomes that were assessed at baseline 3 months and 6 months were the 6-minute walk test, 30-second sit to stand, and hand grip strength test. The KD quality of life 36 short form was used, as well as a study-specific questionnaire also developed to get patient feedback and to hopefully build a program going forward. So half of the patients in this population were female. There was more of a spread of ethnicities. And as expected for an in-center population, the mean age was older, so at 71 years. So again, I'm not discussing all the findings, but benefits patients found were that they felt stronger and more fit for transplant. They found dialysis more tolerable and that it passed quicker and that they were more productive. They were more able to carry out and participate in activities of daily living and enjoy recreational activities. Barriers recognized were the availability of exercise equipment and staff for setup, support, and to give the patients regular feedback. And recommendations for future programs were to offer dialysis at each session. So this program limited the numbers of times a week dialysis were offered, and all interested patients were pooled together to try and include them all in the same session due to the availability of exercise professionals, but hopefully it could be included in more sessions. Patients wanted stretching and mobility exercises to be included, as well as a more diverse array of resistance bands and weights. And again, recognizing the role of exercise professionals, as well as resources to continue the sessions at home. These are some lovely photos, courtesy of Dr. Kiai, with patient consent, of patients participating in the program. The first patient is doing some arm exercises, as you can see. In the second photo, the patient is using the XC bike, which is really very nice and compact and can be used on the bed with quite a lot of resistance applied. So they're cycling while on dialysis. This gentleman is getting a full body workout. So he's doing low limb exercises there with the TheraBand, as well as upper limb exercises while cycling, and of course, while being hooked onto dialysis. This gentleman here has just been cycling on the XC bike, which you can see used on the floor. He's doing some upper arm exercises, and this woman is also using another bike, which is a Monarch bike. This is our volunteer kinesiology student, Joey, who was wonderful in helping us extend the program. This lady is doing some lower limb exercises, and you can see in the second photo the use of leg weights, which I believe are really good for strengthening and falls prevention. So I know this has been a lot of information, and you can imagine this is particularly overwhelming for patients. So as not to overwhelm them with information when trying to discuss exercise with them, our research group developed a one-page reference, pooling relevant resources into this convenient summary for patients to access and find their most preferred online source. So according to most recent guidelines from the World Health Organization and others, we should be prescribing at least 150 minutes a week of moderate intensity aerobic activity and at least twice a week strength training. I've highlighted the relatively new Kidney Foundation of Canada website, which has a wellness hub and tips for staying active, as well as Kidney Beam and Grex, which I'll mention now. On the Kidney Foundation of Canada site, which is still being developed further, there are multiple classes available on the site, as well as other helpful lifestyle and wellness content, such as body image on dialysis and ideas for cooking. It's definitely worth a look. Another great site is the Kidney Beam project. This was born in June 2020, at the time where face-to-face rehabilitation services were cancelled. The steering group was diverse with kidney healthcare professionals, scientists, as well as patients, and they developed the initial content. It's funded by Kidney Research UK, and membership are actually still free and includes live exercise courses, and patients can even enroll in a 12-week renal rehab program. And this resource is currently being assessed in a multi-center study. For health professionals as well as patients, the Global Renal Exercise website is very useful. It's an international group formed in 2019 to foster research and innovation across multiple disciplines to develop strategies to increase physical activity and improve health outcomes for people living with CKD. Through their work, they've built awareness and have managed to implement physical activity programs in dialysis. You can become a member for free, and they're very useful webinars. I recently watched this one on exercise specifically in polycystic kidney disease patients. And a lot of these webinars are also available on Zoom, and they're quite short and concise and are definitely worth a look. Just to show you another resource our group developed for PD patients based on the ISPD guidelines and GREX guidelines with common questions patient asks. The slide might not be projecting fully. I apologize for that. So patients will ask, what can I do after my catheter surgery? So regardless of surgical technique, walking is safe and should be encouraged as soon as possible following catheter insertion. Activities associated with an increase in intra-abdominal pressure should be delayed for a number of weeks post-insertion. Patients often ask if they need to drain before exercise. So any activity that increases intra-abdominal pressure, for example, abdominal crunches, should be done dry. Core strengthening exercises are actually recommended for PD patients, and this is graded 2C, but there's 1C evidence, pretty strong evidence to show that stronger core muscles support the low back and prevent or manage low back pain, which is common in PD patients. Just for some general tips, contact sports, where there's a risk of physical trauma or repetitive rubbing occurring to the catheter site, are not recommended. This is graded 1D, and around 20 pounds is felt to be the maximal weight allowed to be lifted, which is graded only 2D. Specifically looking at exit site care, it's recommended that the exit site should be cleaned immediately after it becomes soiled or wet during exercise, and that the exit site is also cleaned routinely at least twice a week. A common question PD patient asks is if they can swim. The answer is yes. Of course, hot tubs are forbidden, but swimming or other water sports can take place, but they should be in seawater or well-maintained pools to limit exposure to waterborne pathogens, and waterproof dressings are recommended. So my take-home messages after all of that. Physical activity and exercise, I hope I've shown you, is important at all stages of kidney disease. It can improve quality of life, physical function, and certainly some end-stage kidney disease symptoms. Any movement is good, and the best form of exercise is one that can be enjoyed and can be done regularly. There are multiple and more growing free online resources, classes, and ideas, and we should all be encouraging our patients to access them. And in so doing, we really need to promulgate the culture that exercise is medicine. I'd just like to acknowledge some of my colleagues who have helped me with this work and who have allowed me to be involved in their projects. At Providence, so at St. Paul's, Dr. Kiai, who's been a wonderful champion of exercise in her unit, as well as Joey, our kinesiologist, and Tiffany, our rehab assistant, and Vicky, the dietitian at St. Paul's, that's really been instrumental in growing enthusiasm, particularly in the PD program there. Lisa, who is the new Westminster and Abbotsford dietitian, who has been working in this area for a long time and is responsible for the home hemodialysis bike loan project, as well as in-center hemodialysis project. She's been great, as well as Shelley, who's also a dietitian in Fraser, Sherry, and Ganesh, our kinesiologist student, who's helped us develop some videos. From BC Renal, Drs. Copeland and Dr. Singh, who are my, just for the home hemodialysis fellowship, and also for their support with this project, as well as Sue Sanders, who's been really great in helping facilitate this work. And of course, our wonderful patients, such as this Dragon Boat group. O2P is a diverse group of patients paddling for over 15 years together. They aim to provide exercise for people with kidney disease, raise awareness of kidney disease, and of course have fun. They've participated in a few international competitions, and they continue to practice together and inspire. So I conclude with this message that we need comprehensive lifestyle interventions to prevent the cycle of disease and disability in dialysis patients. And I thank you for your attention, and we should have some time for questions.
Yeah, terrific, Megan, and well-timed and a lovely overview of past and current work. So that's great. There are a number of questions in the chat. I'll read some of them and encourage others, if they have some, to raise their hands as well. So there's a set of questions which I'll try and part. They're really about the what our understanding of the physiological changes that occur during exercise in dialysis, and whether it increases or decreases sodium deposition in muscles, whether it predisposes to hypotension, whether it alters gut microbiota, if it decreases splanchnic blood flow, what does it do to myocardial and brain stunning? Like, there's a lot of questions in terms of that physiology. I'm not sure if you can see the questions or if you want me to go slowly, but what do you know about those physiological impacts?
So those are great questions. A lot is unknown, specifically related to the cardiac effects. That's all being studied. So a lot of those studies that I mentioned on clinicaltrials.gov are actually using dynamic intradialytic imaging purely to assess myocardial stunning and the myocardial effect of intradialytic exercise. They're also measuring various biomarkers. In terms of hypertension during dialysis, intradialytic exercise actually gives you more stable blood pressure during dialysis. But of course, there are some, which I showed you that list earlier, some conditions where patients shouldn't participate. The list is limited, but generally it does offer more stable blood pressure. And certainly our home hemodialysis patients that were part of the program had no adverse events at all related to blood pressure while participating in the program. Although there is some nervousness, of course, about patients exercising on dialysis where there are no health professionals nearby, but these haven't been borne out. In terms of brain side effects, a lot is unknown about brain perfusion while exercising on dialysis, but I assume we could extrapolate some findings regarding myocardial stunning to possible brain and circulatory side effects. Gut microbiota, I have no idea. Thank you.
Yeah, no, they're great questions, and I think that's all part of the research, right? Is to actually link the symptom changes and the feelings of well-being to other physiological measures. But as you started, what's important to the patients is less about those things and more about how they feel. There's someone with their hand up, so I'm going to Sivan, just introduce yourself for a moment, if you don't mind. We'll unmute you. Brenda, can you unmute? Oh, 3 more people have their hands up. Great. So Sivan, then you have to unmute yourself to be able to ask the question. Maybe we could, while you're doing that, we could move on to someone else with a raised hand.
Okay, yeah, I'll go to Sunny.
Good morning. Thanks, Megan. You know, when you were talking about the existing data and levels of evidence, I think this is maybe an area where we should abandon this idea of randomized controlled trials. I mean, it's not really something, unless we just want to look at some physiological change from exercise or something. But otherwise, really, I mean, in the natural world, if all these people weren't on dialysis, we would not be randomizing people. We would, you know, just interpret data from the regular population, which I think we can do. You know, if something you're doing hurts you, stop doing it. You know, even us who aren't on dialysis get joint pain when we do some things, and we change what we're doing. So I think the instruction part is important. But I don't really think that randomizing and coming up with these trials is really what's important in this area. Is try to get people motivated, how to find ways to avoid discomfort and encourage, you know, positive outcomes. But spending a whole bunch of time on RCTs is kind of taking away the actual goal of this exercise.
I agree completely. And I thought those comments on the patient feedback were great. And certainly myself, I saw a patient who participated in the St. Paul's program, who I looked after for quite a number of months in the ward. Through participation in the program, she went from pretty much being wheelchair bound to being fully ambulant, strong, building her muscle bulk through her participation. And her quality of life is no doubt much better. She doesn't need walking aids. She's a lot happier. She's a lot more social. So without a doubt, exercise is good for these patients.
Yeah, I mean, I know what you mean, Sunit, about RCTs. I think if you're trying to answer physiological questions for scientific purposes, that they're probably worthwhile. There's also the other way to do that. It's more practical as a stepped wedge where everybody gets the intervention at different points in time. Also just a comment from the executive director of Kidney Foundation of Canada, BC and Yukon branch, Pia Schindler. She'd love to explore how Kidney Foundation could support with resources, perhaps more widely around the province. So that would be a wonderful thing to explore. So thank you for that, Pia. And then there's another question. Are there exercise programs geared for wheelchair-bound patients who are on dialysis? So those who may not have the opportunity to get out of that wheelchair, but are, you know, for paralysis or other reasons. I think it's a great question.
Yeah, so a lot of those resources I mentioned, the online resources, they have different programs for people who have physical limitations. Patients can do upper limb exercises, and some of those pedalers, which I showed specifically the XC bike, you can actually use it for arm exercises quite nicely with resistance application. So yes, and certainly the Alberta program does cater for people with disabilities and helps them show modifications on how to enable them to do exercise. So for sure, it is an area that is included.
Yeah, I think it's about what, I mean, what the message that I think many of us are getting is, how do you normalize it and scale and scope it so that it is just part of the fabric of every dialysis unit? And I think, interestingly, to think about, we think of home dialysis patients as so well, but obviously if you can show that they are weller or stay well, that would be good. So some more hand raising. Sivan, then if you can't, it seems that you can't unmute yourself. So if you don't mind just putting your question in the chat, that would be great. And then Wayne has his hand up. Dr. Hahn?
Hey, Megan, thanks for the excellent and comprehensive review. Certainly want to corroborate that in my time in the geriatric and physiatry world, that all the things you discussed are seen in the non-renal population as well. And so, you know, all the benefits, cardiovascular, frailty, mobility, but certainly from a neurotropic side of things, we know that's one of the single best interventions we can do, exercise. I think we all know that the engagement and motivation is one of the trickiest things with dialysis patients. So I wonder if going forward, one of the things that would be very helpful is to look at how we can sustain the presence of, you know, an exercise champion or kinesiology involvement in the unit going forward. Because I mean, just speaking for myself, I probably need somebody to coach me and give me feedback. And I think there are a lot of resources out there, but you know, I think having somebody that the patients can go to for that kind of information is probably going to be very important going forward.
Absolutely, Wayne. Thank you for that. And we know that a lot of our patients are geriatric and they just become progressively more frail on dialysis. And things like falls prevention is so important in these patients because we know that a fall can be devastating and greatly affect the quality of their life or end their life. I really hope that we can find a way to get exercise professionals involved. I know Dr. Kiai has been instrumental in trying to get a kinesiologist at the St. Paul's unit, and Lisa in Abbotsford, she's really trying to get our kinesiology student more involved in the unit. But I think as people recognize the importance of this, hopefully we can somehow find funding just to at least get someone to show us how to do these things properly and to help us sustain the program long term, because I think it's a really important member of the team. And often this falls on the dietitian's shoulders, which is quite hard because they are often dealing with a lot of other things. They do try and do it, but you need someone that's dedicated to exercise on the team for sure.
Yeah, and I just, you know, as we talk, I just think, you know, there may be ways to, quote, centralize or kind of combine, because I can imagine how difficult it's going to be to find a trained physiologist in every single site and dialysis unit, and perhaps coming up with some creative ways to link 2 or 3 individuals for the whole province would be an interesting undertaking. The other thing that struck me as you were talking is, why do we wait till they get to dialysis to teach them about some of this exercise? Like as they transition from KCCs to dialysis, should we see if we can maintain muscle mass, or is that too overwhelming if it's not part of your regular day?
I'm giving a talk for KCC next week, the KCC education about exercise and CKD on Thursday.
Great.
Yeah, we should be doing that too.
Any other questions or comments that people want to make? Just to remind oh, so Taz actually has a comment. Don't forget that activity and exercise with green prescription and park prescription. So out in nature has its own, that's a really good point, Taz, as well. So outside versus inside is also pretty terrific. Yeah. Yeah, I think there's a lot of interest and desire to propagate this, and I think we need to be creative about the limited resources and talent. But I think the more we normalize it, as you've really beautifully pointed out, the better it will be for all of our patients. And the cardiovascular and other benefits above and beyond the quality of life, which is ultimately what patients need, respond to most, I think is terrific. So it's just the bottom of the hour. That was an excellent, really beautifully put together. Reminder for everybody, the slides and the talk are available on the website, not for downloading, but for listening to. And Dr. Borkum is, I'm sure, happy to talk to anybody who's interested in how to pull this forward or do additional things or send you to resources. And thank you on your slides. The references there are very helpful. And we'll connect with Kidney Foundation and other groups. And thank you very much for the work you put into the talk, but also the work that you've been doing with all the different groups and patients. Thank you.
Thank you.
Thanks, everybody.
Bye.